Hi, Sai. Hi, Viral. See you.
Hello,
Hi, how are you? I'm
I am good, Dr. Poindexter. How are you?
great, thanks.
I'll email.
This is a great article to review for this.
Yeah, pretty interesting. I think we have a lot of good talking points for this.
Good, good. Fun fact is Cami Martin, who wrote the accompanying commentary.
Mhm.
So we went to high school together.
Oh, really?
Yeah, and she did not even remember me. And I'm like, oh no, you sat 2 rows ahead of me in chemistry class. Like I knew exactly who she was. And when she was packing up, she recently moved to Cornell and
Ah,
she found her old high school yearbook. And there was like a little note from me. She's like, oh my gosh, I did know you. And I must have just been a jerk.
it's
I
such a
said, no,
small
I was
world.
just the
Mm,
nerdy one, and you were, like she was the big soccer star. And
yeah.
I
Oh,
said,
she
you
used to
didn't
play
have
soccer?
time in your life for people like me. So,
Nice. So I heard she just moved to New York, right?
yeah, she's
Uh,
the division chief at Cornell. So,
Oh, nice for it. Yeah, it's pretty, the main thing while organizing this, I was worried was the time difference. I was like, man, it was driving me nuts.
yeah, well, hopefully
Uh,
it's like just an early morning for her, I would hope.
yeah,
So,
it's about 8 a.m. for her, so
yeah,
should be
that's not
good
too bad. Yeah.
for it. But hopefully, so uh, we're gonna record this, and we do plan to convert all this into a podcast.
Oh, that's great. That's great.
So at least we'll have those recordings. I'm trying to work with the AAP. I applied for
Yes.
an educational grant, so I can use those grant to convert all this into like podcast and stuff like that.
Yeah, you guys have done a great job with all this.
Yeah, it's been fun
Yeah.
for it. How's Atlanta? How's your daughter
Good.
doing?
Good. She's great. Yeah, actually, we gave a talk together this week for her division. She did a rapid review of
Mhm.
neonatal emergencies for the ER doc. So, we went through differences in NRP and PALS, and
Mhm.
I taught him how to do an emergent umbilical line, and
Oh, nice.
yeah, we kind of went through shocky neonate and picked some things they might see. So that was
Yeah.
fun.
I'm gonna have Ariel Salas also join us today.
Oh,
So
awesome. Awesome.
Sai's on service, and I'll be busy with the technical stuff of it.
Yeah.
Um,
Yeah.
we'll let
Love
him.
Ariel.
Yeah.
Session is a pleasure to introduce Dr. Brenda Poindexter, an esteemed neonatologist and recognized expert for us in neonatal nutrition. She began her career as neonatologist at Indiana University, and then she moved to Cincinnati Children's to begin her role as a director of clinical and translational research at the Perinatal Institute. And in 2020, she became the division chief of neonatology at Emory University in Atlanta. And her career has been very successful. She has led numerous studies on neonatal nutrition, including some multi-center randomized trials through the NICHD Neonatal Research Network. And she has multiple publications, over 120 peer-reviewed publications, and she also has an important role in neonatal nutrition as the editor of the book, as one of the editors of the book, Nutritional Care in Preterm Infants, which, as many of you know, is a very comprehensive resource for most healthcare professionals interested in neonatal nutrition. So her trajectory has left us with a lasting impact on the field. And Brenda, I sincerely appreciate your willingness to provide mentorship during this journal club session.
Thanks, Ariel.
Thank you so much. Nupur, stage is all yours.
Awesome. Thank you everybody for joining us today in this session. My name is Nupur Asudani, one of the first year fellows at Children's Hospital of Michigan. I would like to begin by saying a great thanks to Dr. Jen for giving me this opportunity to present today at the AAP section on Neonatal Perinatal Medicine Journal Club. And also a big thanks to Dr. Harding and Dr. Poindexter for taking time out to be here as mentors and giants in the field of nutrition. I would also like to thank my faculty at Children's Hospital of Michigan for guiding me and for their immense support. So today I will be talking about the article that's early amino acids in extremely preterm infants and neurodisability at 2 years. This article was published in New England Journal of Medicine in November 2022. This article is based on the PROVIDE study, which is protein intravenous nutrition on development. Before I begin my presentation, I would like to disclose that I have no conflicts of interest today. And then I will be using the CONSORT 2010 checklist for reviewing the article, but I'll go through that at the end of the presentation. Just to give a review of the contents, I'll be going through the background of the study, the objectives, the methods used, the outcomes both primary and secondary, the randomization style used, the statistical analysis, going forward to the CONSORT diagram, the results, and then the most important, the discussion of the paper. We'll end with the strengths and limitation of the study, and then discussing further possibilities in the field of nutrition. So just a little background of why this paper and this topic is important. We all know in the last 2 decades, several advancements have been made in the field of neonatology. However, nutritional optimization of our extreme preterm infants remains a topic of debate and research, especially in our sick and preterm newborns, which are at risk of malnutrition and growth failure from an inability to receive protein at a dose that was equal to what they were receiving in utero or in the womb. Studies have shown that placenta supplies approximately 3.5 grams per kg of amino acids to a developing fetus. And if the baby is born preterm, this abruptly disrupts the amino acid supply. An infant's energy requirements, approximately 10% of that is provided by proteins. Now, why are proteins so important? Proteins, which are made up of amino acids, are building blocks of our cells. They're indispensable to tissue renewal, regeneration, and repair. So going forward, looking at the blue boxes, if we have enough protein in our body, this will promote adequate anabolism, leading to proper body and brain growth. And this in turn will improve our neurological outcomes going forward in our preterm infants. However, if we look towards the left of the table, if there is insufficient protein, this will lead to catabolism, leading to tissue breakdown and negative nitrogen balance. So there's always a debate of what is sufficient amount of amino acids. There have been studies in the adult critical care area where they have shown that excess protein in the TPN can lead to risk of protein intolerance, particularly in those that have impaired kidney functions, leading to azotemia, increased BUN, ammonia, leading to metabolic disorders. The European Society of Pediatric Gastroenterology, Hepatology, and Nutrition in 2018 came up with guidelines on pediatric parental nutrition, specifically for amino acids, where they recommend starting amino acids on the first postnatal day in our preterm infants at a rate of 1.5 grams per kg per day. And they recommend going up on the amino acids from the postnatal day 2 to about 2.5 to 3.5 grams per kg per day. This should be accompanied by non-protein intakes of more than 65 kilocalories per kg per day and adequate micronutrients like calcium and phosphorus. They currently do not recommend using amino acids more than 3.5 grams per kg per day, except as a part of clinical trials.
If I could just interrupt there, because you're absolutely right. But at the time this trial was started, we started in 2014, and we were planning it, of course, in 2012. The recommendations were for 4, not 3.5.
Yeah, I think they revised their recommendations in 2018. I think this was also based on the 2018 Cochrane meta-analysis, which looked at about 35 studies to see higher versus lower amino acids in the parental nutrition. However, they did not find high quality evidence to state that higher amino acids does not have any effect on mortality. They also saw that higher amino acids may reduce incidence of postnatal growth failure. However, this evidence was also a low quality evidence. They saw that higher amino acids may be associated with potentially adverse biochemical effects leading from excess amino acids, leading to including azotemia and metabolic disorders. And the most important was insufficient evidence to show an effect on neurodevelopmental outcomes.
So I think it's a good time to pause and revisit the background a little bit, how those numbers of 3.5 and 4 came, and how good was the evidence at that time while you were designing the study. The placenta showed that we need 3.5 grams, but we know preterm infants has much higher caloric requirement considering they're in an outside environment and ventilated and stuff. So Dr. Harding, starting with you, do you mind walking us through the history?
I think coming back to the fetal supply, the placental supply is around 3.5, but fetuses also get about another gram per kilo per day through swallowed amniotic fluid. So their actual intake in fetal life is closer to 4.5 grams per kilo per day. And of course, at birth, all that gets cut off. And following the ESPGHAN guidelines or any other recommended guidelines, it takes several days to build that protein intake back up. There's a big gap between birth and somewhere around the end of the first week when most recommendations would get babies back up to somewhere around the 3.5 grams per kilo per day. So that it's that first week big gap that we were trying to address. Would early extra protein make a difference? And as has just been nicely pointed out from the Cochrane reviews, there was some evidence for benefit for growth of higher intakes, but no studies that were adequately powered to look at neurodevelopment. So there's a real gap in evidence, and the recommendations had over the preceding decade for maximum intakes being going up and up and up from 2 to 2.5 to 3 to 3.5 to 4, based on better growth. And then there were 2 big randomized trials in older children in intensive care and in adults, suggesting that increased nutrition might actually adversely affect neurological outcome and mortality. So there was a real need for addressing the protein intake, particularly in the first week, but having a study that was adequately powered to look at developmental outcomes.
Right. Dr. Poindexter, do you have anything to comment on the background?
Yeah, well, it's interesting how the pendulum, I think, shifts. And, without, I guess, giving away my age, when I was a fellow, it was very, very common that these babies, less than 1,000 grams would only receive glucose for the first several days of life. And now all of you are probably thinking, oh my gosh, why were you starving babies like that? But we really didn't have the evidence to know really what the impact was going to be. And I think, where we have really, really sound evidence is that giving 1.5 grams immediately after birth will at least put you in a state where you have no protein loss. And so it's not going to meet all of the needs, but you will at least limit protein breakdown. And you guys may be going to talk about this later, but I think the other thing to keep in mind is that with all the advances we've made in neonatology, we are using the same parenteral amino acid solutions that we were using 30 years ago. And really the way that the chemists came up with the composition of the solutions we're currently using was really through a series of iterations of changing the amino acid concentrations to match the plasma amino acid profile of a term breastfed infant. And so I think this audience clearly understands how our 24 and 25 weekers are so very different. And so I think anytime we're talking about changes in neurodevelopment, realizing that, you know, while this study took on, I think, the really important concept of the quantity of protein, you know, I think that sort of what I would like to challenge this whole group is to think about the quality of amino acids that are delivered as well.
That's great. Nupur, you can proceed.
Yeah, thank you for the comments, Dr. Harding. I think she said basically what I was going to say next. Out of the 35 studies that were included in the Cochrane analysis, only 2 studies looked at neurodevelopmental disabilities, and the total participants in those 2 studies was just 201. They also did not show any significant difference between the higher amino acids and the lower amino acids group. Since there was such a lack of randomized controlled trials that were powered to look at the neurodevelopmental outcome, this study does fill that gap, like Dr. Harding said. So going towards the objective of the study was to determine whether the administration of amino acids at an additional 1 gram per day, starting within 24 hours after birth and continuing for 5 days, would increase the percentage of children who survived without neurodisability at an age of 2 years, which was corrected for gestational age at birth. So going forward towards the methods of the study, so this was a multi-center parallel group, double-blinded, randomized, placebo-controlled trial, where participants were divided in 1:1 ratio between the intervention group and the placebo group. This study was carried out in 2 sites in Australia and 6 in New Zealand. And then duration of the study was from April 2014 to October 2018. And the final neurodevelopmental evaluations were conducted in May 2021. So all the infants that were born with birth weight less than 1,000 grams and had an umbilical artery catheter were included in this research study. And the exclusion criteria were for babies who were admitted to the NICU with more than 24 hours after birth. If there were multiple gestations of more than 2 infants, that is triplets, quadruplets, if they had any known chromosomal or genetic or congenital disorder that may affect growth, presence of any inborn error of metabolism, and a danger of imminent death. So looking at the intervention, so the intervention group had infants receiving an extra 1 gram of amino acids and 1.4 grams of sodium in 12 ml of fluid, whereas the placebo or the comparison group got 0.45% saline in, again, 12 ml of fluid. So the volume of fluids that both the groups got was 12 ml, and they received this extra fluid through the UAC. Both the fluids had heparin in them, and the rate of the fluids was 0.5 ml per hour.
So Dr. Harding, so you designed the intervention this way. Is there any specific reason to do? Did the previous studies which tried to aim for a higher, not able to achieve the higher? Was that not enough separation between the 2 groups?
It's the real difficulty with designing a trial with higher and lower protein intake is making sure it actually happens. And we're all aware of the challenges of making sure that the amount of nutrition prescribed actually gets to the baby, because infusions get interrupted, drugs are needed and transfusions are needed and so on and so forth. And it's quite difficult to actually ensure the baby gets the prescribed amount of nutrition. It's also difficult to manage things like, and there was a query in the chat about it, what happens if the baby's urea climbs, or people are worried about the ammonia level and measure an ammonia level, and perhaps change the nutrition as a result of that. The rationale for this was that these babies got the intervention through the umbilical artery catheter, which was otherwise only being used to give saline to keep the catheter open, so it's not providing any nutrition. And all other aspects of nutritional care stayed the same. So that ensured that there really was a difference between the groups provided by the study fluid, regardless of what was happening with all the rest of the nutrition and all the inevitable interruptions and variations in clinical practice. This was intended to be a pragmatic trial. Did it work in practice? We had 8 different units with 8 different nutritional protocols. And the intention was to give it a study fluid that was not going to be interrupted or distorted by all those other things. And we really would achieve a difference between the groups, which has been a problem with all previous studies.
Jane, can I ask a quick question? What is the practice, I guess, in these centers in terms of enteral feedings with an umbilical arterial catheter?
So the feeding practices were quite varied across the units. And in fact, we've done quite a lot of work on that and published some data about how variable it really was. It was a great surprise to us how variable it was, but most of these units would start enteral feeding with an umbilical arterial catheter in place, at least in minimal feeding. And the other thing is, although the intention was to provide the fluid for 5 days, it didn't mean the umbilical artery catheter had to stay in for 5 days. If it was removed because the clinicians thought it was no longer needed, then that was the end of the intervention. So we weren't insisting on a catheter staying in to take part in the trial. Simply was there. Again, it's pragmatic. It's a clinical pragmatic study. We used the arterial catheter for as long as it was there.
So related to that aspect of care, was there a lot of variability in the duration of parenteral nutrition across centers as well? Related to just the variability of enteral nutrition, I guess?
Huge variation. I will look while we keep talking and put a reference to a couple of publications in the chat for people on how much variation there really was.
Right.
Yeah. Nipper, you can proceed, please.
Okay. So going forward to the outcomes, so the primary outcome was survival free from any neurodisability at the corrected age of 2 years. Neurodevelopmental disability was defined as cerebral palsy, blindness, deafness, developmental delay, which was measured on Bayley's scale, 3rd edition, where any score that was less than 1 standard deviation, less than the mean, was considered as developmental delay, and then gross motor function classification system score of more or equal to 1 for cerebral palsy. And there were a lot of secondary outcomes that were looked at: intraventricular hemorrhage, cerebral hemorrhage, periventricular leukomalacia, PDA, which was diagnosed on echo and then treated, necrotizing enterocolitis of stage 2 or higher on the Bell's classification stage, chronic lung disease, which was defined as need of supplemental oxygen at 36 weeks of postmenstrual age, retinopathy of prematurity, stage 3 or higher. Only on in the New Zealand sites, serum concentrations of urea, calcium, phosphate, and ammonia were measured at the end of the intervention, that is at the end of 5 days. Length of neonatal unit stay, infant growth, which was measured as Z-scores for height, weight, and head circumference, and then body composition at 36 weeks postmenstrual age. There were some post hoc analysis that were done for degrees of neurodisability, refeeding syndrome, which was defined as serum phosphate of less than 1.4 millimole per liter, and for our US population of less than 4.3 milligrams per deciliter, and then total serum calcium of more than 2.8 millimoles per liter, or more than 11.2 milligram per deciliter on day 5 after birth. And that was after the intervention was finished. And then sepsis, early onset, and probable late onset were also added post hoc. So for evaluation, the primary outcomes was evaluated at 2 years corrected gestational age. This was done by Bayley's 3, a neurological exam, evaluation of the executive function, which was a brief for preschools, and child behavioral checklist. Enteral and parenteral fluid intake levels were recorded daily. until day 28, as well as the mean daily protein, energy, and other nutrient intake levels were also calculated. So going forward to the randomization, so the patients were recruited by clinicians and researchers, and they were allocated 1:1 into the research group, which was the intervention group, or the placebo or control group. If there were twins, they underwent randomization as individual infants. The assignments were made by the means of this a web-based interface that was maintained and concealed by an independent database controllers. And then randomization was conducted with the use of variable block sizes, which was stratified according to the recruitment site, the sex, and the size related to gestational age. IRB approval was taken at each participating sites, and then informed consent was obtained. Most consents were obtained prior to birth. However, there was a concept of delayed consent where infants were randomized and received intervention within the first 24 hours, provided that they got a written consent within 24 hours. So for blinding, the parts.
It perhaps is just worth commenting on the consent process, because it's always a problem with trials where you want to have an intervention very close to the birth of a very preterm baby. How do you get informed consent if you can't get it before birth? And often you can't, because this baby just arrives. So the New Zealand sites, but not the Australian sites, because we have different ethics committees, gained permission for a delayed consent. That is, the babies were randomized and started the study fluids as soon as the umbilical artery catheter was ready, provided that we could get consent within 24 hours. So that gave us 24 hours to be able to talk to the families and give them some time to consider. If they said no, they did not want to participate, then the study fluid was removed, the babies went into standard care, and they were not included in the trial. We'll see that in the consort diagram shortly. But it was very helpful to give some time for a reasonable period of informed consent, which is otherwise quite difficult.
Yep.
That was not allowed in Australia. I don't know if it'd be allowed in different places, in different units on the people on the call, but it is something to think about.
Dr. Poindexter, do you want to comment about the delayed concept in the US, considering you have led so many of the trials?
Yeah, I think, Jane, I mean, I really, it's exciting to hear that they were able to do that in New Zealand. And it would be an interesting side conversation to understand how the families perceive that. But I think, especially for a lot of delivery room interventions, whether, I think about like the SAIL trial or some of the different cord clamping trials, even some of our phototherapy trials, it would be nice to have time for the, things to settle down so that you could feel like you were having, a better conversation and really an ongoing consent conversation with the families. I know that John Tyson has done a lot of work in this space, and I'm not sure that, we would be able to get that through in the US, but, I think it would be great to continue to pursue that, because I think it's really the only way we're going to be able to address studies that could look at some of these questions where the intervention does need to be, so timely and close to the time of birth.
Yeah, that's great. Thanks for New Zealand for leading the way in that. Nupur, can you proceed, please?
Yes. So going towards the blinding process, the participants' family, the clinical staff, investigators, assessors, and members of the data and safety monitoring committees were blinded to both the intervention and the placebo fluids throughout the trial was run, as well as until the statistical analysis was performed. An independent contractor compounded both the fluids in the one in the intervention and the placebo group, and they were identical in appearance, and they could only be identified by a randomly generated number identifier. They were both run through the UAC, and like Dr. Harding mentioned before, it was separate from the TPN, so as to give a consistent higher amino acid. in the intervention group. So the sample size was calculated to provide an 85% power with a two-sided 5% level of significance, taking into account a 10% loss to follow-up and a 50% risk of neurodisability in the placebo group. Keeping all of that in mind, a sample size of 430 was obtained with 215 infants in each group. Different statistical methods were used for all pre-specified outcomes. Modified intention to treat was used, which included all the infants that were randomized, but did not include the ones where parents did not give consent within 24 hours. For per protocol analysis, all the infants that received 80% of the assigned amino acid or placebo fluid were included, and then analysis were performed using SAS software. For linear models, they were used for analyzing outcomes between groups and with adjustment for stratification for site, sex, and small for gestational age. Linear regression models were used for continuous variables, and for binary outcomes, a modified Poisson regression model with log link was used, and calculated robust standard error estimator was also used. For all the pre-specified subgroup analysis, the stratification was done for sex as well as for small for gestational age status. And for post-hoc group analysis for neurodisability, sepsis, and refeeding syndrome, the stratification was done only for small for gestational age status. So going forward at the consort diagram, 981 infants were assessed for eligibility, out of which only 499 underwent randomization, which is 50% of how many infants that were initially assessed, which means 50% were excluded, which is 482 patients, which is a pretty high number. Out of the 482, 240 did not meet eligibility criteria, whether it was unsuccessful insertion of the umbilical artery catheter, or they were admitted more than 24 hours after birth, being more than 2 multiple gestations, having chromosomal or genetic abnormality, congenital disorder, or danger of imminent death. About 20% were eligible, but parents or guardians declined consent. And about 30% were eligible, but the 24-hour period for obtaining delayed consent was missed. So looking at the 499 that underwent randomization, 249 were assigned to the intervention group and 250 to the placebo group. For the 249 that were assigned to the intervention group, 32 were excluded for several reasons, like parents and guardians declining participation, not providing consent within 24 hours, died before consent could be obtained, or underwent randomization in error, leading to a total of 217 that were recruited. Same on the side of the placebo group, 250 that were randomized, 33 were excluded for the same reasons as that of the intervention. And in the end, 217 were recruited, which were equal in both groups.
It's worth just noting there on the point we were just discussing, if we could just go back to that previous slide.
Yes.
About consent. You can see of those who were randomized, only about 10% of parents declined after randomization. So it was mostly pretty acceptable to parents.
I mean, that's really an exceptional consent rate. I don't know of many trials with that high of a consent rate. So I think you all are to be really, probably the coordinators, right? To be congratulated for such a great job on that.
That's of the ones who were randomized. You can see further up, there were quite a lot who declined to be randomized.
Sure, sure.
But of those who were randomized, only 10%. So the delayed consent didn't seem to be a big issue for these families.
Right.
Okay, so moving forward, of the 217 that were recruited in each group, about 38, 39 died in the intervention and placebo group respectively. That was prior to discharge. So about 82% in each group were discharged alive. Fast forwarding to 2 years, 1 infant in the intervention group and 3 in the intervention group died after discharge, but prior to the 2 years age marks, leading to about 81 and 82% survival. So these infants were assessed for neurodevelopmental outcomes. Looking at the intervention group, 13 infants were not assessed because of decline from parents for participation, loss of follow-up, or they moved overseas. So 165 were assessed, which is about 76% of the total recruited, or 93% of those that were alive at 2 years. Same on the placebo side, in which 10 were not assessed for reasons of loss of follow-up or moving overseas, and 165 were assessed at 2 years of age mark. I think it's important to look that the follow-up rate in both the groups was excellent. 93% of those, or 94% of those who were alive at 2 years were followed up for neurodevelopmental outcomes at 2 years. So overall, 203 infants were included in the primary analysis in the intervention group, and 205 were included in the primary analysis in the placebo group. This just excluded a total number of infants whose parents declined consent, and there was, I think, 1 infant that was there was no data available in the intervention group, and 2 in the placebo group. So looking at the neonatal and maternal characteristics at baseline, the age, the socioeconomic status, the race and ethnic group, and education were pretty similar in the 2 groups. And just to point out that the distribution in the socioeconomic status, there was a higher predominance in the quintile 5, where quintile 1 was least socioeconomic deprivation and quintile 5 was most socioeconomic deprivation. But it was clarified in the paper that most preterm infants that were born to females with lower socioeconomic backgrounds. So it was representative of the population. And then there was a predominance of Caucasian race group, which is something that we could discuss in the end as to the generalizability of this trial to other populations. Looking at the infant characteristic, that there was pretty much this same in the both placebo and intervention group. But I would like to pull focus on the gestational age, which was a mean of 25.4 in the intervention group and 26 in the placebo group. I would like to ask Dr. Harding and then Dr. Poindexter if they think this is significant. I know it's a randomized trial and we don't have p-values, but in such preterm infants, even 3 days does make a difference. So I'm not sure if what your thoughts are on that.
The birth weights are almost exactly the same. We didn't think that was of any clinical importance.
Okay. Yeah, looking at the birth weight, they were pretty much the same, 770 mean in the intervention and 789 in the placebo group. Same for the birth length, the head circumference, and the sex distribution.
And reassuring that there were no differences in those with intrauterine growth restriction, it looks like.
Yes, even the SGA population was 10% and 12%, 10% in the intervention and 12% in the placebo group. So this is a chart that looks at the mean parental amino acid intake between the two groups. The pink line demonstrates the intervention group and the black, the placebo group. So we can clearly see that in the first 2 days, there is a higher, clear difference between the two groups, where with a mean of 3.4 in the intervention group and a 2.6 grams per kg per day in the placebo group. However, as we go forward in our days to 3, 4, and 5, there is some significant overlap in our range, and then after the intervention is over, the amino acid content in the intervention group does go down. And I think that's probably because, like Dr. Jane said, that the UAC, if it was not clinically needed, would probably be removed earlier, which is why there was a significant overlap on day 4 and 5.
And just to clarify, those numbers are the mean for the week. The 3.4 and 2.6 are the mean over the first week. So that includes the days 6 and 7 where they're coming back together again.
Awesome. Okay. Now looking at the primary outcomes, so the primary outcome was survival without neurodisability, out of which 97 in the intervention groups had survival without neurodisability and 102 in the placebo group. So looking at this table, it shows that 47.8% in the intervention and 49.8% in the placebo group were free from any neurodisability at 2 years of corrected age. There was no statistical difference between the two groups. However, when we looked at the subgroups of neurodisability, looking at any neurodisability among survivors, there was a 40.9% incidence in the intervention group and 37.4% incidence in the placebo group. This was not statistically significant. However, when we looked at moderate or severe neurodisability among survivors, there was a significant difference between the intervention and the placebo group, where there was a higher incidence of moderate and severe neurodisability in the intervention group of 16.5% as compared to 8.6% in the placebo group.
Harding, want to comment on what you're expecting? The surprising results for it. It's still a secondary outcome. How do we interpret these values as trainees?
Yeah, I think you have to treat secondary outcomes with caution. The primary outcome, survival without neurodisability, is not different. But as we'll go on to see, that there's a remarkable consistency amongst many secondary outcomes suggesting a worse outcome in the intervention group. And I think you put more weight on the findings like that if there's a whole lot of them that all go in the same direction, which I think Nupur is about to tell us about.
Now, I have a question about the prevalence overall of survival without disability, close to 50% in a group of patients that include babies up to 31 weeks. That, at first glance looks high, considering that there were 29, 30 weekers in that cohort. But is that kind of average? Because I remember seeing that the sample size was calculated based on a reference from 2012. So I was hoping that, in the subsequent decades, maybe the trend was a bit lower, but it sounds like it's still about the same.
Yeah, I think the sample size was estimated to be on a 50% incidence in the placebo group, which is almost exactly what we found.
Yeah.
That was from the Epicure study, so it was a population-based study in the UK. I think what data there is suggesting that actually we haven't got very much better at changing outcomes. We've improved mortality, but the developmental impairment is not changing much over the decades. And it's also worth remembering that this is a very inclusive definition of impairment. So it's the mildest version is only 1 standard deviation below the mean. So most or many reports that you read of impairment after preterm birth are only including the moderate and severe, whereas this includes the mild as well. So we weren't very surprised. We were sort of reassured that the placebo group numbers were almost exactly the same as the power calculation, because one of the difficulties of power calculations is that if you estimate your basal rate wrong, then you don't have the power that you'd hoped.
Fair point. And I think I've been part of those conversations about, who do you group those infants with mild disability? Are those babies that should belong more with the non-disability group, or they truly are reflective of moderate to severe? And that's why sometimes even in discussions about primary outcome, why would you choose survival with free of disability versus, moderate to severe disability and death, and how the concept of composite outcomes and which one should we target from an epidemiological perspective. Some people will favor to target a negative, to prevent a negative outcome, and those are usually the ones that favor the prevention of moderate to severe disability or death. And
yeah, I think
I don't know if there was any conversation about picking one or the opposite, the positive outcome or the negative outcome that we want to prevent.
Indeed, there was lots of conversation, as you can imagine, but the reason for including mild disability in this is that our sense is that even children who fall between 1 and 2 standard deviations below the mean on a Bailey scale really do have challenges in education and in development and in survival in our world and should be included. And the other thing is, when one is counseling families before birth, what they really want to know is, what are the chances of my baby being normal when they go to school, which is essentially this primary outcome.
And Jane, are you all doing school age follow-up of this cohort?
We're currently seeing them at 6 to 7 years of age. We're about halfway through.
That's great.
Nipur?
Okay, so just retouching, like Dr. Jane said, that there were multiple, like 3 secondary outcomes that pointed that the intervention group had a significantly higher rate of moderate civil disability. This was also seen in the cognitive delay on Bailey's and on the composite language scores, which were significantly lower in the intervention group as compared to the placebo group. Looking at these secondary outcomes, they were pretty similar. The incidence of all of them are pretty similar in the intervention group and the placebo group, except for the PDA incidence and then the refeeding syndrome. So looking at the PDA, about 54% of infants in the intervention group had PDA as compared to 42% in the placebo group, which was statistically significantly higher in the intervention group. Refeeding syndrome, which was a post hoc analysis, also there was a higher incidence in the intervention group as compared to the placebo group. Looking at the lab values, which were looked at the end of the intervention or at 5 days of birth, the serum urea and calcium concentration were also significantly higher in the intervention group, and then the phosphate concentration were lower in the intervention group. However, the serum ammonia concentrations were not significantly different in the 2 groups. Looking at the other secondary outcomes, the length of NICU stay was similar in the 2 groups. The infants in the intervention group did have a lesser decrease in the Z-score for weight between birth and 4 weeks. So they were, heavier at 4 weeks, but this was not reflective at 36 weeks of postmenstrual age and at discharge, in which the infants in the 2 groups were similar. Macronutrients and fluid intake levels in the 2 groups was also similar, other than, of course, the first week of intervention. And then the time to reach full enteral feeding and the type of feeding at the time of hospital discharge were also similar in the 2 groups. So going on to the discussion, based on the study, we do see that the administration of amino acids at a higher dose of 1 gram per day for the first 5 days after birth did not see any significant difference in the incidence of death or survival without neurodisability at a corrected age of 2 years. In fact, the results were consistent with a possible increase in moderate to severe neurodisability among infants who did receive the higher amino acids. Now, again, like Dr. Harding said, that the study was not powered to look at the secondary analysis, so caution, of course, needs to be applied while we are looking at these results. But there were 3 secondary outcomes that did point in this direction. The infants in the intervention.
So I think it's a good time to recap all the results and how do we interpret for future studies, or how does it change our practice? Dr. Harding, starting with you, how do we take this results, which are all in a consistent negative trend or showing increase, and does this affect future studies or our practice if we want to give higher protein?
Well, there's 2 things. One is there didn't seem to be a benefit for growth, and all of the rationale for gradually increasing the recommendations about protein intake over the last decade have primarily been on the basis of better growth. It doesn't appear that the extra protein actually did improve growth and may have had adverse effects. So I think there's two things. I think it does support the current ESPGHAN recommendations that doses higher than 3.5 grams per kilo per day should only be in the context of a trial. Secondly, that the group who did not get the intervention, who had a mean intake of around 2.6 grams per kilo per day in the first week, that appears to be enough to optimize growth because the extra didn't improve things anymore. So we probably need to be less worried about getting up to the 3.5 plus grams per kilo per day. And the third is, I think it's actually quite difficult in the face of these data, at least until we have more follow-up data, to conceive of a study where one might want to intervene with higher protein intakes than were used here because of the likely adverse effects.
Dr. Poindexter, do you have any comments?
It's maybe more of a question, but I'm still intrigued a little bit at the amino acid intake for babies in the control group and how the actual intake may have differed from what was prescribed, because I do think in a lot of places, the amount of times per day that the infusion gets interrupted, for a medication or for blood. And, the averages were not really at that 3.5 gram mark. And so, you wonder, were the clinicians still not prescribing the 3.5, or were they? And it was more that there were interruptions such that what the babies actually received wasn't quite what was intended. The second point, there's a comment in the questions that I think is that I'd really love to have Dr. Harding address, is that it really was the same dose for a 500 gram baby versus a 900 gram baby. And, do you think that there's, perhaps some differences there where the smaller baby would have been getting substantially more additional protein than, say, the baby that was closer to 1 kilogram?
Yeah, just to clarify, the numbers in the paper are the actual intakes, not the prescribed intakes.
Right,
So
right. That was
recorded every single interruption and every fluid they had and so on and so forth.
No, that's
So-
actually my point, that it's surprising, I think, that the actual in the control group was a little bit lower than what our recommendations would be.
Yeah, and we don't know what they were prescribed. We only
Right.
know what they actually got. And I think, again, it reflects the very wide variation in practice and what babies actually get. But nevertheless, on average, there was a gram per kilo per day difference between them actually received. The issue of the intervention, therefore, for a 500 gram baby was essentially 2 grams per kilo per day, and for a 1,000 gram baby was 1 gram per kilo per day. We had a lot of debate about that. We decided in the end that that was just the way that was most pragmatic to do the trial. And indeed, if it showed a benefit, that was the likely most pragmatic way that it would happen in practice. You just put up the fluids at a standard rate and leave it at that. I've put in the chat some of the references, particularly to the paper describing ammonia concentrations, which were only very, very weakly related to amino acid intake. Some units, but very few of them, measured urea regularly and adjusted the TPN appropriately, or as they saw fit, should I say. Whether it's appropriate or not, we don't know. But they were blinded to what was in the TPN, what was in the umbilical artery catheter fluid. So the whole variation in practice that happens for a zillion different reasons happened in this trial as well. And you're right, maybe we would have expected a higher intake in the first week in the placebo group if babies were actually getting a recommended prescription of 3.5 grams per kilo. But I think that does reflect practice, even if they were prescribed the higher amount. What they actually got was 2.6. But that seemed to have been enough to ensure growth.
Absolutely.
Going back to your publications related, I wasn't aware of them to be honest, and I wanted you to share a little bit the experience of publishing before the actual randomized trial. I think will be important for this audience because no one wants to get into a clinical trial just because sometimes you have to wait for the results to be completed, especially with this outcome of neurodevelopment, which you know is going to take at least at minimum 4 years. So was it hard for the reviewers to accept this preliminary results? I noticed that none of them were analyzed according to randomization, but were there any concerns from the reviewers about having this secondary analysis before the primary analysis being published?
No, because they're not secondary analyses of the trial. You're right. They're not analyzed by a trial group. They're cohort studies.
I see.
So in the cohort of babies who were in the study, what was happening to their nutrition, what was happening to their ammonia levels, and what was happening to mortality and how did that relate to nutrition? Those are cohort studies, completely unrelated to the intervention.
Okay, great. Now, the one thing I wanted to ask you if there was any concerns about this findings on parental protein supplementation being extrapolated to enteral protein supplementation. You know, I don't know if people, I mean, I'm a strong advocate of actually early enteral protein supplementation, thinking that might actually help with growth. And sometimes I'm worried that this finding could be interpreted that all protein, regardless of the source, could be seen as potential with the potential increase of moderate to severe disability that could actually limit the intake. I just checked with the 2022 SPGAN recommendation about enteral nutrition, and they still recommend up to 4.5 grams per kilo for enteral. Has that come up as a concern at some point with the study sites about limiting enteral as well, or it's very clear that this could be related to just
not at all, because this is only the first 5 days. You know, there's very rare less than 1,000 gram baby who gets up to 4 grams per kilo of protein enterally in the first 5 days.
Right, that's correct.
They're only talking about the first few days of parenteral nutrition.
Nupur, you want to proceed?
So looking at the secondary outcomes, but the infant in the intervention group did have more incidence of PDA or patent ductal arteriosus that did need treatment. The results, I mean, this did kind of confuse me, and so I was hoping Dr. Harding would clarify if this was included in the regression analysis to see if this was just like an incidental, babies in the intervention group had more high incidence of PDA, or was this related to the amino acids? Just to see if this was a confounder or a mediator in any way.
I can't explain the finding. It's a secondary outcome of a randomized trial, so it's likely to be related to the intervention. The only association we've found is with refeeding syndrome, which was also higher in the intervention group. But the association is not explained, at least not by us and not in the literature that I'm aware of. Because the fluid volumes were the same, which was our initial response.
Yeah.
And we did check on the sodium intake for the same reason, and it's essentially the same.
Okay. So do you think we should, going forward, we would account for like PDA in the regression analysis and see if those who didn't have PDA would have the same neurodevelopmental outcomes? I'm not sure if that was affecting the neurodevelopmental outcomes.
Yeah, as a post-randomization outcome, so it's not one that you would adjust for in the analysis.
Okay.
But I think your question might be, could the PDA explain some of the adverse outcomes? We can't determine that from this randomized trial. You'd have to randomize babies to having a PDA or not, which would...
I would guess the timing of that diagnosis might have been highly variable as well. So
it was routine in these units to scan between days 3 and 5 and to treat. So it wasn't very variable.
Okay,
There's
that's
some
interesting.
variation, but not much.
Okay. Yeah, I was just concerned as to whether this was a confounding factor or was it a mediator to our outcome of neurodevelopmental outcome, which would be interesting to look forward in future studies as well. And then going forward to the refeeding syndrome, we did see there was a higher incidence with hypophosphatemia. And we do understand that, when babies are born and there's a cutoff from placental supply of nutrients, the amino acid will cause higher insulin levels, causing more, hypophosphatemia with increased internal phosphate. Also, when there is increased anabolism, there will be more utilization of phosphate. So my question, Dr. Harding, were the electrolytes balanced in the TPN? Were the clinicians balancing for like low phosphate and high calcium levels in the TPN, not knowing, of course, what intervention that the babies were getting?
Again, it varied across units. Most units weren't measuring calcium and phosphate in the first few days, but it was entirely up to the clinicians. Certainly they were measuring and adjusting as necessary for other electrolytes. I think since we did the analysis of the incidence of refeeding syndrome, again, I've put that reference publication in the chat. Since we did that analysis, we have reviewed local protocols and changed the monitoring and the calcium and phosphate content of the TPN, and other units have done likewise. But that was after the completion of this trial.
Awesome, that's good to know. Thank you.
I think it's worth saying at the time we were planning this trial, which, as I said, was around 2012, there was no real consensus that refeeding syndrome was a real thing in neonates. I think it's easy to forget that that's sort of become a real thing in the last 10 years rather than everybody being convinced it was a real thing in 2012.
That's true. So looking at the strengths of this article, so this trial was a randomized double-blinded controlled trial, which is the highest form of trial that you could have. They did receive the sample size that they had calculated, and it was obviously larger than all of the previous trials. There was an excellent follow-up rate, which I think is really good. And then there was a lot of robust data that was prospectively collected. And I think it was ingenious to give the amino acid through the UAC to separate it from the TPN amino acids. So there's a clear-cut difference between the intervention and the placebo group. Looking at the limitations, and I think the first one was mentioned in the article, that infants who did need the umbilical artery catheter may have been more sick, and there was no segregation of infants by severity scores, illness scores. There were two different kind of formulations for amino acid that were used, primine and then trophamine, and I'm not sure if there was any difference between the two, between different sites that could have been, a contributing factor. Also, then we've touched based on this before, that the amino acids that probably were used in the TPN may have varied among centers because everybody had different nutritional guidelines. And for refeeding syndrome, the serum levels of magnesium and thiamine were not measured. So that is something that I think we can look forward in future studies as well.
So is there truly much difference in different formulation of amino acids, and is there like a better quality amino acids coming through, which could be further studied?
Gosh, I wish, Farrell, it's been hard to engage with any of the companies, that make these products. And, I kind of go back to what Ariel was saying too. I think I used to feel much more strongly that we needed new products. And now I really do think with our tiniest preemies, the greater emphasis that we put on early enteral nutrition and trying to get babies off of TPN, I'm a little more, I think, ambivalent about, how pressing of a need it is. Certainly for some of our babies with intestinal failure or surgical conditions where they're going to be on prolonged TPN, perhaps they would benefit more from improvements. But, you know, if there was a company willing to invest in doing those studies, I think that would be great. I guess, you know, then the question maybe for a group like this would be, what would you want as your primary outcome if you were testing a new amino acid solution? And, you know, how do you think about that in the context of all of the other things we're doing to these babies, both nutrition and other kinds of intervention? And, you know, I'm not sure how you would design that study, but would love to hear, you know, what other people would think about that.
So, Dr. Harding, you want to comment on this?
No, I was hoping you'd tell me. I've puzzled over the same things. Even if we could get a company to engage, what would we aim for? What would be the outcome that we would be aiming for? And in reality, to get a robust answer, you'd have to do this kind of study with great long-term follow-up, and it'd just be a nightmare. But I agree with the point about getting babies onto enteral feeds as soon as it's feasible seems to be an important component. And just to clarify the two different formulations of amino acids, that's what the neonatal units were using in their routine TPN. The intervention was only trophamine.
Oh, okay.
Regarding enteral nutrition, I noticed that the time to full feeds was an average, I think, 18 days versus 16 or 19 versus 16 between groups. Is that reflective of current practices in those sites? Is that the average time to full feed around 2 weeks for these babies less than 1,000 grams?
It's reflective of the variation between sites, and the publication on variation will give you an idea of that. For some sites, it was as early as a week, and for some sites, it was as late as 3.5 weeks.
And was there any clinical profile of this refeeding syndrome? I know you use a very operational definition based on biochemical values, but and I was trying to read through the paper that you have on refeeding syndrome, and I couldn't really identify any sort of specific symptoms. I was wondering if there was some sort of feeding intolerance as well as a result of refeeding syndrome, since what's described in adults with this particular syndrome is usually related to very specific symptoms, fatigue and sometimes not wanting to eat. So I was wondering if that could have an impact on even enteral feeding practices in a way.
It could have done. I mean, it is a biochemical definition, and there may well be associated signs. Certainly, there were associated morbidities and mortality in our cohort.
Yeah.
I can't tell you about feed intolerance. I don't think we looked, but I can't remember to be sure.
Sounds good. Do you want to finish your final few slides?
Yes. So sorry, going through the CONCERT 2010 checklist, I think this trial did meet most of the criteria. The ones that I have not highlighted are probably not applicable to the trial. There were no changes that were done in the outcomes of the trials once it was started. And then there were no interim analysis or stopping guidelines. And also there was no reason for a abrupt stop to the trial as well. It did meet most of the things that we discussed today. In discussion, so like, is my patient so different from those in the study that the results cannot apply? Now that's actually a very interesting question. And when I was looking, I was talking about the baseline characteristic. Now that those may not be applicable to every population that different hospitals cater to. But I was looking at the Vermont Oxford network incidences of different secondary outcomes that were looked in this trial, especially for like infection rate that was about 11.3%, and infants that were born between 501 gram and 1,500 grams. And then chronic lung disease, even with IVH, ROP, those seems like lower than what that was, documented or reported in this trial. So I'm not sure if that in any way had an effect on the neurodevelopmental outcomes.
I think you need to be careful for comparing a group from 500 to 1500 grams as opposed to
I was
less than
gonna
1000
say.
grams.
Yes, I
Very
understand.
different group.
Yeah. No, absolutely. But there was no difference that was given in different grams. This is what I could find, but there's something to kind of keep in mind in terms of generalizability of a study. Going to the treatment feasible in my setting, and I think, yes, this is something that can be replicated in most NICUs. It was a clear-cut intervention and methods that were described in the study, which I think can be applied in any NICU as well. Will the potential benefits of the treatment outweigh the potential harm of the treatment for my patient? I think the study does clearly, tell us that there were no difference in the survival without neurodisability in our children who were receiving higher amino acids. So I don't think there were any potential benefits. And then, of course, we did see the incidence of higher moderate to severe disability in our babies, which obviously we should be cautious about. So I don't think I would in our setting. And of course, please, Dr. Poindexter and Dr. Harding, chime in here as to what you think about this.
I agree with you, Nipur. I think that, I do still see sometimes in our units, people kind of pushing the prescribed amino acid intake to 4 to 4.5 grams. And it always makes me a bit uncomfortable. So I think that this, I think that this study really does an excellent job of sort of giving us that warning that more isn't always better. And there's an excellent commentary that accompanied this publication in the New England Journal by Cami Martin, that if you haven't read it, I would, highly recommend it. Because I think, while you might not, do the intervention of giving an extra gram, in the umbilical catheter, I think there still are a lot of people that kind of say, oh, more is better. And I think this should be a caution for that practice.
So I think that was a great discussion. I think the trial clearly answered more is not better. And I have asked it a long-standing, it took almost like 9-10 years from conceptualization to publication to answer this question we have for it. And many thanks for doing that, for it solves a lot of dilemmas. But I think for future trialists who are here, I think a lot still remains to be studied on the enteral feeding domain for it. So any comments about that? So which could inspire a future trialist in the audience here?
Yes, I think there are plenty of opportunities there. It's resource-wise, I think as long as you have access to donor milk, I think you can definitely try. We can generate more trials. I think many studies have been done in developing countries about early exclusive enteral nutrition, and I think it's about time for us to explore some of those approaches in high resource settings and see if we can improve outcomes through that. I did notice that there was some centers that wanted to do body composition. I guess the numbers were the paper reports that there were too few. We talk about less than 100, less than 50, probably. Yeah. So I think that's the other outcome that I think it might be important to see in the future, to see if it's not just weight, but it's actually lean mass gains. So plenty of opportunities there.
We did have body composition at 2 years in these children, and it was the same in the two groups.
At 2 years.
So yeah, Dr. Harding, any comments about where the future nutrition trialists should focus their attention on?
No, as I said earlier, I think it would be difficult following this trial to design another similar trial of higher versus lower intravenous amino acids early on in this group of children, because I think, there's a clear pointer to likely risk and no advantage is what this trial is telling us. But that doesn't answer the question about advantages or not of higher protein intakes enterally. or in many other macro and micronutrients. And I think there are some important trials to be done about the routine use of fortification and how much fortifier and what should be in fortifiers, if anything. We have, just as the recommendations for IV amino acids have sort of went up and up and up, and now we go, oops, maybe not. I think we may be in the same position with enteral supplementation, with a serious lack of trials with long-term outcomes again.
Thank you so much. Thank you, Dr. Nupuro Sudhani. That was a great presentation, very well discussed. Any final closing comments, starting with you, Dr. Poindexter?
No, I would echo your comments. Viral, I think that Nupur, you did an excellent job discussing this. I think this is just a phenomenal example of a very well-designed, well-executed study. And I hope that it really inspires everyone who's listening, because I think it was really important. And I think, looking for some of the aspects of our practice that we just sort of take as gospel, and we don't step back and think, are we potentially causing harm? I think this is just such a great example of that. And there's so many aspects of both nutritional support and other aspects of neonatal care where we can and should be asking similar questions.
Dr. Harding, any more final thoughts?
Thank you, Nupur, for that lovely presentation. Thank you for having me and talking about this trial. I should just acknowledge that, of course, it's not my trial, it's a whole huge team. And as you point out, 10 years work by a big team. Don't let that put you off trials. Trials are like that. They're incredibly frustrating, but if they answer the question, if you actually have an answer, that's really valuable. And when we first looked at the data for this trial, Barbara Cormack, who'd done a lot of the leading of it, was very disappointed and said that wasn't what we hoped to find. We really thought it would help. And Frank Bloomfield and I, who were the other two senior people, said, well, at least we have an answer. At least we know now. And that's the real value of big trials. Even if they don't tell you what you hoped you would find, at least they give you an answer.
I think that's a great message for all the young trialists in the audience here. And thank you very much for sharing this with us. So in the interest of time, I'd like to close out this session. Thank you all so much for attending. We hope we'll see one of you again in the future sessions.
Yeah.
So much.
I would, sorry, Dr. Jen, just to interrupt,
sure.
I would just like to say thank you to Dr. Poindexter and of course, Dr. Harding for mentoring us today, and for being so encouraging to us trainees to, look for answers, even if those are not the ones that you're looking for. So thank you so much for inspiring us.
Thank you. Thank you so much, Robin.
Thank you.
Bye.
Thanks. Bye.